Rahim. Ladies and gentlemen, good morning to everybody. It is the first day, first session, and we are going to start with scattered complicated cases and management of issues. So to start the session, we will start with the recitation of Holy Quran. Bismillahir Rahmanir Rahim. Qul huwallahu ahad, Allahus samad, lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Sadaqallahu al-azim. Jazakallah. Since it is first session and first day, people take time. Some people are loading their presentations over there. Some are getting their bags from the registration desk. But still we have some nice of you, all of you, my colleagues and juniors and seniors to be here. I welcome you all. And with your permission, I will like to start the session. चेयरपर्सन हमारे मजरी साहब भी हैं, एजाज लतीफ़ हैं हमारे को चेयरपर्सन, और मैंने मॉडरेट करना है. तो विद योर परमिशन हम स्टार्ट कर रहे हैं. प्रोफेसर मोइन साहब का सेशन है, पहले प्रेजेंटेशन है. पोस्टर कैप्सूलस मोइन साहब का फेको आईओएल एंड रोसो, removal of silicone oil through a single incision. So Professor Moin, to start please. Thank you.
Assalamu alaikum everyone. Thank you very much Professor Majid Malik for inviting me to give this talk. My talk is going to be on phaco IOL and removal of silicone oil through a single incision. I welcome everyone to the 41st Lahore Ophthalmo and the 7th APOTS meeting over here. Yeah? Okay. So there's no financial interest. Whenever you have silicone oil in the eye, when you use it for retina surgery, complications can happen. Second to that, and here you can see you've got silicone oil which is emulsified. You can see the particles of the emulsified oil which is seen over here. And then you can see oil particles can collect behind the intraocular lens. The oil can emulsify in the anterior chamber, and this is called a hyperolean. And here you can see the oil is present over here. And these oil particles can clog the anterior chamber, the angle of the eye, and they can lead to secondary glaucoma. So if you put oil in the eye, the patient can go blind because of glaucoma. So he will not probably go blind because of retinal surgery, but he can go blind because of glaucoma. And this is how it looks like the oil on a B scan. Here you can see the particles floating in this. So the time of removal of silicone oil is chorioretinal adhesions are usually formed by 1 month, and the oil can be removed between 6 weeks to 6 months. And it may be left in eyes with poor visual outcomes, and heavy silicone oil is not left more than 3 months. So the type of lens, eye oil is important. The lens status is important, whether the patient is phakic or aphakic, and if any other procedures are needed along with the removal oil. So oil removal can be done either through a single port, which I'll show you later on. You can have a 2-port system, or you can have a 3-port system for the removal of oil. And the removal can either be as a passive aspiration of oil, or you can have an active aspiration, meaning that you have a vacuum pulling that oil. And the third is manual. The active aspiration can be with a machine, or it can be manual. And passive aspiration removal means that you are injecting fluid and the oil comes out just because of the pressure that is going in from the inflow which is happening. The important tips which you need to remember for removal of oil is keep the tip of the cannula within the oil globule. You should not have unwanted hand movements which leads to a lack of hold. Small bubbles are difficult to sort of get hold of due to fluid turbulence, and at the end, gentle pressure can be given to the ciliary body so that the oil particles go into the center. Maximum suction applied is limited in machines, so pressure driving the force. So here you can see this, if you have fluid which is coming in from one side, the pressure in passive suction, it takes the fluid out. So if you have something, if you think you're injecting with a syringe on one side, the fluid will go through the other side. But here you're using the hydrostatic pressure of the drip or the irrigating fluid to get this thing out. So this is the atmospheric pressure and the infusion pressure which is forcing, which is going inside, and it is going to replace the oil which is inside. So the oil moves to the other side, and removal of oil is just removing curd, or जैसा मलाई आप कर लें तो दूध के ऊपर float करती है. तो the similar thing, when you put fluid in the eye, the oil is going to float up and it is going to go out from the other port over here. The other thing you can do is you can have an aspirating pressure. So you have drip coming on one side and then you're aspirating, and the aspiration can be with active aspiration. You can do with your manual aspiration, or you can have a machine. So machine vacuum or manual vacuum, and the length of aspirating cannula is important, because if there's the more length of the aspirating tube, then the amount of pressure gets reduced because of that, because of Poiseuille's law. So procedure in combined and phaco-Rosso is a primary posterior capsulotomy. Infusion anterior chamber maintainer is used, and in aphakic eye, silicone oil can be removed just from the anterior chamber. So I'll just go on to the video. Chale. So here you will see that we have done we're doing phacoemulsification. This was a medium size pupil. And once you finish your capsulorhexis, you're going to do a hydrodissection. Then you do a careful phacoemulsification. The problem which you can get in patients with silicone oil is the zonules can get weak. Then you can get deep anterior chamber when the oil is present. And here I'm just doing a vertical chop to remove that oil. And once that oil is removed, then once that lens is removed, then you would remove the cortex and then make an incision in the posterior capsule to get that oil out. So the main challenge is that you're going to make an opening in the posterior capsule, and that if it's not done carefully, you can lose capsular support and you might not be able to put an intraocular lens. But in experienced hands, probably here I'm doing a posterior capsulorhexis, making an incision in the posterior capsule. Now you've got the anterior capsule, and as soon as you make that incision, an oil bubble can come forward, but you need to be careful and use Utrata forceps to make that opening big. So I'm using an 18 gauge. This is an 18 gauge Venflon or a Brenla, which has been cut, and it's going into the vitreous cavity where the oil is present, and I'm using active suction on the other side to remove that oil. So this is the last particle of that oil which comes out. And once you have removed the oil, the other thing is going to check that if you've got a good capsular bag. If that is, you can easily put a single piece IOL in the bag. The other way you can do the same thing is you can remove the lens, put the IOL, and then go from behind and then remove the oil. But this is a one go procedure through which you can do both things at the end. Next slide. Next slide. So next, let's go video on. So this is another video showing that was a single port. This is going through two ports. I'm going to make two ports. One is you're going to get infusion of fluid, and from the other you're going to get removal of oil through passive when the fluid goes in. So this is the infusion cannula. So you can think of the fluid is going in and it's going to replace the oil, and that here I'm putting, you can see the length of the suction tubing is small so that it can good aspiration, and you need to keep that aspiration most of the time, especially at the end, because if you lose that oil bubble at the end, you can have difficulty, and that oil bubble might be difficult to capture or catch at the end. This is the sunset sign when the last droplet of oil comes in, and it is most important to keep that cannula in place over at that time. Here you can see this is receding, and this is the complete oil removal. The third thing you can do is you can put a third port, and if you think the oil is emulsified, you can go back and you can do multiple exchanges of air fluid exchange and remove any small particles of emulsified oil. So the take home message is potential risk of retinal detachment when you're going to remove oil. So you always explain to the patient they are higher in eyes with PVR or high risk of PVR. And most detachments occur within 6 months. At the end of removal of oil, you should check with indirect ophthalmoscope to see if there's any retinal detachment or hole formation. And longer axial length or myopia is associated with higher risk of detachment. So prophylactic 360 laser is usually essential before you are going to remove an oil. It's difficult to sometimes ensure that the oil is completely removed at the end if you have a free emulsified oil. So that's why you can do multiple air fluid exchange to remove that oil, and this can be done. So this is soup and sandwich technique. So once the oil is removed, you could just do an air fluid exchange, and then you're just removing that top part of the oil which is floating on the fluid and remove this. And this is the skimming technique which I'm showing you, that you can just go in and remove the particles. So the flute needle is kept at the air fluid exchange. This is just, if you've got small particles of oil in the anterior chamber, you can use a 1 cc needle and go in and remove those oil particles very easily without losing the anterior chamber by just having a 1 cc syringe there and remove that. If the infusion cannula is on, then it's usually much easier to do. Here you can see the fluid, the oil particles. So in this type of tickle patient, you will have to do multiple air fluid exchanges to get that emulsified oil removed. So in conclusion, choose the best approach, 1 port, 2 port, or 3 port. Be careful during the procedure, prevent hypotony at any stage, and counsel the patient about complications. Thank you very much.
Thank you, Professor Main, for a wonderful talk and videos. You made us aware of many things, especially those who are not retinal surgeons. Now I request Professor Ejaz Latif to make us versant about tricks and tips of management of posterior polar cataract. Posterior polar cataract has always been a very difficult issue, and he will tell about the problems, how to face and how to manage them. He is a very experienced surgeon, and Ejaz Latif, please.
Today we'll discuss some important points about managing the posterior polar cataract. Now the posterior polar cataract, as you know, is a sort of heaped up cataract, and it's projecting in the posterior cortex like a cone or like a hemisphere. And the important thing is that quite often this is adherent to the posterior capsule. And if we do hydrodissection, during hydrodissection, the jet of the fluid can go backwards through that and create a hole here. And usually we end up PCRs, posterior capsule rent, in such cases. So we have to be very careful in such cases of posterior polar cataract. And the important thing is that it's recognizable only on the slit lamps. And it's very difficult to identify it directly on the microscope. So the documentation is very important. Whenever you see a case of posterior polar cataract in your clinic, just make it very clear on the documents and highlight it, that is a posterior polar cataracts, and we have to do hydrodelineation technique instead of dissection. So many of it's also associated with the posterior lenticonus, and this lens capsule is very, very delicate here. So what's hydrodelineation technique is just separation of the endonucleus from the epinucleus. Instead of separating the cortex from the epinucleus, we separate the endonucleus from the this epinucleus. You see, this is lens, and this is endonucleus, and this is epinucleus. And this is cortex, posterior capsule, and the cortex. So usually we go like this, the fluid waves go like this, but here we penetrate deeply downwards, and we separate, identify a plane, and then separate it, the nucleus from the endonucleus. The jet wave should go like this. So we identify the plane and just pull it little back to create a space for the fluid, and then inject small, identify it, and then complete this. So we sorry. No, we have to play this. This is video. देखें कैसे now see, now I'm going a little deep as compared to cortex. I'm going deep into the epinucleus and then identifying the plane. Inject very small amount of the fluid here and identify this plane. See, this cut is identified, and then inject liberally, slowly, to separate the endonucleus from the epinucleus. Now here you can see that I'm taking out the endonucleus only. The epinucleus is still there, intact, and is preventing the posterior capsule rent, even if it is primary posterior capsule rent. There is a thick layer of the epinucleus and the cortical complex. So you see that it's undisturbed. This is another case with a soft nucleus. Now, in case of soft nucleus, especially in such cases where there is chances of PC rent, I use this technique, which I am showing for the last few years to you. And you can see that it's still undisturbed here. So the nucleus is removed, and the epinucleus and cortical complex, as well as the posterior polar cataracts, still are intact. So there is no chance of nucleus drop in such cases now. Now this is what is left behind when you remove this. You find this hole. Usually it's in cortex, but you should consider that it's in the posterior capsule until you start your cortical aspiration very carefully, and you find that this is intact. So the important thing is that we should clearly document and highlight on the patient's chart that this is a case of posterior polar cataract, and it's better if your assistant can remind you at the time of hydrodissection, which we are using hydrodissection, that he should remind or she should remind you that it's a case of posterior polar cataract, and we have to do hydrodelineation, not hydrodissection. So the tips are, one thing is the documentation. Number two is the larger capsular axis, will help very much. Suppose you do 5.5 capsular axis. In this case, you can go to 6. Slightly large capsule axis will decrease the pressure on the posterior capsule during hydrodissection and do hydrodelineation instead of hydrodissection. Bottle height down so that there is less fluid and less pressure in the anterior chamber and will not open the posterior capsule rent if it is present. And during irrigation aspiration, empty the cortex fornices first. Capsule fornix should be cleared first and then come to the central part of the cortex. And I told you many times it's associated with the posterior lenticonus. And when you have removed this, you find a very, very thin capsule, which is very flail capsule, and there are some powder-like deposits on it. Don't try to polish it, because it will, with a very delicate touch, it will rupture. So if you want to polish this posterior capsule, do it after you have implanted the lens. Thank you so much, ladies and gentlemen.
Thank you, Professor Jaz Latif. Any comment or question, please?
ये बात मैं आपको बताना चाहता हूँ कि Dr. Professor Akal Qazi is my mentor in phacoemulsification. So I have learned a lot from him actually in the beginning, especially.
Very nice
I used
talk.
to come to him.
Now this patient has come to you and he wants that I want to have a toric IOL, I want to have the trifocal IOL. Are you going to go ahead with this?
Sorry sir, I can't understand.
You have identified a patient with a posterior polar cataract. Yes, and the patient wants, I want a toric, I want a pentoric. So are you going to say yes or no?
Yeah, I will say yes, but it will be conditional. I will tell him definitely that there are chances of a complication, which usually happens is, but I will try to avoid this complication, and hopefully we'll end up with the toric or multifocal. Otherwise, I can go with the simple. If there is precedent, then we can go with the normal lens. But surely, most of the time, you see how many cases we are doing. Lot of cases of posterior capsule, and rent is very, very rare, and it always happens when I ignore this hydrodelineation. I don't remember, and I was thinking something else, and I have gone to hydrodissection, and the rent occurs. In the very beginning, you see that the pressure is high inside, and the lens is pushing forward. So we can definitely implant the lens, because this happens very rare, not in all cases. Maybe 1 in 20 cases of posterior polar cataract.
The important take-home message is we have patients, and we have patients in our own profession, doctors, and the doctor have been told that you have a special cataract there can be a gap in the posterior capsule, and a cardiologist, professor of cardiology at the moment. So once we did one eye, the capsule remained intact. And when he came after a few months with the second eye, we saw him on the slit lamp and we could see the posterior capsule split. There was a gap. The posterior capsule had an elliptically was not there. There was no problem with the surgery because he was a young man with an intact vitreous AVF. When there's intact vitreous, you don't have any issue of lens drop. When the liquid is vitreous, the AVF is not intact, then if you put a pressure in the anterior chamber, things go back. So we should know that once we commit something, we don't have multi-piece toric, we don't have multi-piece pentoric, which is available in America. So
Very good observation.
we'll just stay with the...
बहुत अच्छी ऑब्जर्वेशन है आपकी. Not only that the posterior capsule has problem and may have problem, we have big capsular recesses in these patients because of surgical requirement. And big capsular recesses, again we have to think twice for implanting premium IOL, especially the phenoptoric and other premiers. Because in these patients, peripheral area is more, lens fixation may be not that good, especially if the toricity is involved. So it is tricky, and we should always be guarded unless we have experienced hand of Dr. Rijaz Latif. Thank you.
Thank you so much, ladies and gentlemen.
Thanks for a wonderful case and discussion. I hope Dr. Carlo is around. Yes. Welcome, Dr. Carlo. Very nice. Good morning. You are here and you have a lot of presentations. So you will go by one or
I was not expecting that topic. We didn't.
what is your topic?
Yes.
We have three of you.
I saw this topic, but I mean, nobody informed me on this topic.
So what are your
I am presenting the Carnevale IOL.
This
now.
stops here?
No, this one, nobody informed me of this, these topics, you understand?
Which topic is yours?
Is Carnevale IOL principles, and after 12 o'clock, there is Carnevale IOL complication. Nobody informed me on this program.
You can go ahead with that.
Okay.
Good morning, everybody. Thank you to Professor Kagan Hussein for the invitation. I'm going to talk about a relatively new model of intraocular lens for scleral fixation. On 2012, I had the idea to put a small harpoon on the top of a close-optic common intraocular lens in order to fixate a lens to the ciliary sulcus in case of lack or absence of capsular support. And since from the beginning the procedure worked perfectly, so I presented in the European Congress of Cataract and Refractive Surgery the first 9 cases. Which is the principle? This hook, this T-shaped plug, works like an harpoon, and you can see once it's pulled through the thickness of the sclera using a microforceps, opens on the other side of the ciliary sulcus and stabilizes the lens to the sclera without any need of stitches. Which is, how big is the plug? The plug is 0.3, and you can see here how nicely is deep in the sclera, is buried without any sign of inflammation or deformation of surface of the sclera. Even the plug has some modification. In the beginning, it was like a hammer. Now is like an hourglass. Why? Because I noticed that if the shape is like that, there is a slight risk of erosion or movement of the plug in the thickness of the sclera. In this case, the scar of the tissue around the neck of the plug stabilizes the plug in the thickness of the sclera, so less risk of late surface erosion. But this lens is not only a plug, a hook, an harpoon. There are other things inside it. You may notice some small notches on the 4 arms that are connecting the optic disc with the loop. These are weak points, so this lens can be adapted to different diameter of ciliary sulcus without any modification of the distance between the cornea and the IOL. So this lens has a very good refractive predictability. Then you may notice how big is the loop. The loop is like a wing. So this loop can fit in the ciliary sulcus and touches in the ciliary sulcus in 3 points. The 2 shoulders of the loop and the T-shaped plug. So this lens has no risk of tilting along the axis that are connecting the 2 T-shaped plug. So this lens has a very good 3-dimensional stability. And you may remember that the vaulting of this lens is 10 degrees, so there is less risk of iris chafing or a reverse pupillary block that is very common with the Yamani technique. How implant this lens? There are two basic procedures and many variations. We can make a flap 4x4 and then bury the plug in this scleral flap. The forceps is inserted and engage the plug of the leading optic and externalize it. So once the plug is outside, opens like an harpoon, and the lens is fixated to one side of the ciliary sulcus. The same thing for the leading optic. Again is externalized, and the procedure is practically finished. The lens is stabilized to the ciliary sulcus. Just to show, what is important, at minimum 4x4 scleral flaps. This is an explant first. Then this is the lens loading. You may notice here insertion and the forceps engage and externalize the flap of the leading optic. Same thing with the trailing optic, and the procedure is practically finished. There is a short version of this procedure. This is the follow-up. How is anterior segment OCT and anterior segment photo, no sign of inflammation. Then there is a shorter procedure, 2 radial cutting opposite to the sclera, 2 small pockets with a crescent on the 2 sides of the 2 radial cuttings, insertion of the microcoaxial forceps, then starting to deliver the lens, the forceps engage the plug, and all the lens can be delivered in the anterior chamber. At the same time, the forceps should externalize the plug, and temporarily the plug is on the surface of the sclera to avoid to drop the lens down. Then with a microforceps, you can bury it and move the 2 wings of the plug in the 2 small pockets you have previously sculpted. And the procedure is finished. This is the same case. You can see here the radial cutting, and the plug is translucent under the conjunctiva and deep in the sclera. This is the same patient, anterior segment OCT. This is a new idea from our colleague Evangelos Manousakis from Greece, which is implanting this lens through the Hoffman pockets, which is absolutely a wonderful procedure. He punches the sclera, externalizes the plug, and then with the Sinskey hook or as some instrument, pulls back the plug from the surface of you can see here, from the surface of a conjunctiva, he pulls back and the plug slips in the Hoffman pockets. So in this case, the lens is implanted without touching the conjunctiva. As every procedure, we need to know exactly the tip and tricks. It is mandatory to have 2 microcoaxial forceps curved, not straight, because if we have a deep-set eye, big nose, or a prominent frontal bone, you will never be able to engage the plug. So it is mandatory to have curved forceps. Always try the forceps in the scleral hole before inserting the IOL, because during insertion of the IOL, you have 2 hands busy, so you need to know that all the way in the thickness of the sclera is smooth, and the forceps is well tested. It's a big lens, overall diameter 13.4, so you may have a risk that some part of the loop can be catched between the cartridge, when you close the cartridge, or between the cartridge and the rubber piston, and you may snatch some part of the lens. So you may deliver the lens inside the eye, which has been already damaged. So it's mandatory to load properly the lens. Always engage the plug before inserting the IOL in the anterior chamber, because especially in the fully vitrectomized eye, you may drop the lens down in the vitreous. So it's mandatory to be careful during that step of the procedure. It's important to protect the sclera, the plug, putting enough sclera around. Minimum 3.5 by 3.5, better 4 by 4, scleral flap or scleral pocket, same. And remember that you always will have a smaller flap you have already prevented, because once you sculpt the flap, the sclera shrinkage, so you will have a little smaller side. And remember to suture the conjunctiva to avoid any complications, because you don't want to have a exposure of the sclera in the day after the surgery. Thank you, everybody.
Thanks, Carlo, for a wonderful presentation on scleral fixation, a newer technique which makes us more stable and more confident about post-operative results, and cosmetically as well. Any comments or any question of any of the colleague? Carlo, you have been must have been operating with the previous scleral fixation techniques, Giovanni, etc. How do you find the difference of your cases between previous scleral fixation lenses and this one?
There is a echo. I can't hear you properly.
My question is that you must be operating scleral fixation lenses in earlier as well with the previous lenses. This is a newer lens, no?
There is?
Your lens is the newer lens, this T-loop lens. You must, how you differentiate your experience between this lens you have shown us today and the earlier technique in your own experience?
Yes, I think you heard, the most common procedure all around is the Yamane. Because Yamane is comfortable because you use lens that already have in your stock. You have 3 pieces lens, so you have in your stock, so it's easy. If you are in trouble, you can use Yamane. But the Yamane uses a standard 3-piece lens, 6 millimeter optic disc diameter. Which is the problem? The problem is that has much more risk of tilting and has much more risk of decentration. This lens has been purposely designed to avoid that. That's why I have explained it, how it's difficult that the Carnevale can tilt it, because it has many points of touching in the ciliary sulcus. And even if you decentered, we will see afterwards for the complication, even if you decentered the lens, you will see there will be no problem. Instead, if you use a 6 millimeter diameter lens in the Yamane, if you have a slight decentration, you may have problem on the vision with the patient.
Thank you, Carlo, for a wonderful talk and making us versant with the newer technique of scleral lens. And any other question, please? There's echo. There's a problem of echo as well. Is it available all over?
I don't know. Basically, I don't know. I don't think so. I don't think so at the moment.
So you have to customize and you have to ask for it. Thank you, Carlo.
Thank you.
Now I will request I have Dr. Linda. No. Dr. Khalid. Professor Khalid Mahmood is here. He is a wonderful corneal surgeon as well as phaco and glaucoma surgeon, well known to me and for everybody for ages. Now he is going to implant IOL phaco surgery in a patient who has been operated for corneal graft earlier. Dr. Khalid, please. It is always difficult to do phaco surgery in patients who have all complications, like we have already seen this posterior cataract or in corneal graft. Cornea is not as healthy as we have the normal cornea. So, Dr. Khalid will make us versant with it.
Bismillahirrahmanirrahim. Actually, this is a difficult challenge when we deal the cataracts in cases of the corneal transplant. These are the actually three situations which you have to face. The patient can have a coexisting cataract with the corneal opacity or corneal scar. The second is you have done the corneal transplant and then you have an accelerated lens changes which troubles the patient vision. And number three is the refractive lens exchange. When we have the coexisting cataracts, we can go straight forward to the open sky cataract extraction with the IOL. In cases of the accelerated lens opacities, you have done the corneal transplant and you have the accelerated lens cataract. You have to remove at an early stage because patient is unhappy after the corneal transplant about his visual outcome. So you can have either the irrigation aspiration or you can have the phaco IOL in these cases. The third situation in which we go for the refractive lens exchange, usually this is on a later stage. You can remove the sutures, you can remove all the sutures, and then you can go for an toric IOL in these cases, particularly in the cases of the keratoconus, where you can have some of the residual refractive error, and then you go for the toric IOLs in these cases. What are the common issues? In all of these scenarios, the IOL calculation is one of the challenging in these cases because you have refractive, the K reading errors in the biometry calculation of the IOLs. You can have an estimated K or the K of the other eye, contralateral eye, then you can have to go for the IOL calculations. The graft survival rate is the most important thing you have to think about it when you go for these cataract management in post or during the cataracts, during the corneal transplant. The ESCRS phaco complex series shows that normal ECD loss from phaco is 5 to 9%, and the normal rate of ECD loss is 0.6% per year. It increases 2.5% per year after phaco emulsification. So this is the first case I want to show you. Video jalayenge? So this is the first case where we have the coexisting lens opacities with the cataract. You can attempt the phaco emulsification open sky. It's a difficult challenge. Then it's easy to have the cataract extraction, open sky cataract extraction. This is the lens removal. You can have a bimanual technique of the removal of the lens. You can see here. It's simple. After you have done the triple C or with the, then this is the simple. You can go for the irrigation aspiration. This case, this is a young patient who came to me with fungal keratitis. I did the corneal transplant 2 months back, but she got an accelerated lens opacities. You can see here the cataract here. It's almost a mature cataract, and you can see here that you cannot find the round actually pupil. So you have to do in these cases early cataract removal. Be careful about the visualization of your capsule. The trypan blue, you can use it, but use it under air because everything is toxic to the endothelium, particularly these types of the
solutions, the trypan blue or myostat, which we inject. Look here, I have just nicked the anterior capsule, and there is gush of cortical soft matter. It's very difficult in these cases to have a triple C. I'm using micro scissors to cut, to make entry into the anterior capsule, but it is a very tough capsule. So keep your force inside. Don't lose the margin of your capsule. You can see here, it's very difficult to have a round CCC. I'm going from the other side to cut the capsule to make it a little bit rounder. Yes, so this is a soft cataract. So I didn't need to have to phaco in these cases. This is a soft cataract. Use viscoelastic multiple times as you need to protect the endothelium. You can see here, the soft matter is coming out through the Simcoe. This was the retroillumination. Do not hydroimplant in these cases the IOL. Always use the viscoelastic shell to protect your endothelium. When we go for the phacoemulsification in these cases, what should I have to change? You should have to go for the soft shell whenever it is possible with the dispersive OVD. Adaptive IOL calculation to consider the variable K values. Patient counseling is very important. You have to tell her or him that the visual outcome will not be so much as compared to the other people. There are risks of refractive outcome, decompensation of the grafts. So when we have to go for the phacoemulsification, we have to reduce the phaco energy because there is free radical injury. IOIP changes are very important. Temperature, that can damage to your endothelium. Fluid flow also. You have to maintain all of these, and you have to adapt your phacoemulsification setting. Yeah. This is the phaco case. I'm using the soft shell technique in this case. First, the dispersive, and then you can use the HPMC under that. थोड़ा फास्ट कर दो बस ठीक As I've said, always use the viscoelastic when you are implanting the IOL. What else? You should be ready for that. The distraction fish mouthing of the wound, because the wounds, they are soft, so there are high chances of iris prolapse. You may need an additional suture. Reduce the visibility, may need trypan blue. Ensure your IOL material is compatible, that's the hydrophobic acrylic, and have a plan for possible capsule tear. And I tend to use the standard divide and conquer approach with biannual irrigation or with your Simcoe. So the key message is that when you have an added maneuver, you have added risks. So the most important message is that in these cases, when you are dealing with the cataract in corneal transplant patients, please, you have to save the corneal endothelium. And that is the most important point. Thank you very much.
Thanks, Professor Khalid Mahmood, for wonderful discussion and presentation. Some things are newer to us, and Uthilium is more important. Any question and comment? Any experience to be shared with the cataract surgery in case of corneal graft?
Yes, excellent surgery, thank you. Very complicated cases, very well done. Can you hear me? Because I know there's an echo there.
No, I'm close to the speaker now.
Okay, so my only question is, to make your life easier, could you not have used some sort of iris or pupil dilators, iris hooks, Malugan ring, whatever, to make your life a bit easier?
Nice. So that's a beautiful tip. One or more things I have to add in these cases is that when you have the entry point in the cornea, you have to save the host and graft junction. Because when you made an entry with 2.5 or 2.8 keratome inside, so you can damage the host graft junction, and then you can detach iatrogenically the decimus membrane. So this is very important. The point is that can we use the iris hooks in these cases? Yes, we can. But if you definitely need it, because I have said additional maneuver will cause the additional risk to your corneal endothelial graft. So if the pupil is not dilating properly, or in these cases comorbidities are there, you have an additional, you can have the posterior synecdoche, you have an undilated pupil, then yes, you can have your iris hooks or your Milligan rings, you can use anything which you are used to in these cases.
The case of soft cataract, irrigation aspiration was used. Irrigation aspiration was buckling the cornea. And buckling cornea means we are affecting the health of endothelium. So my recommendation will be, strong recommendation will be that the phaco irrigation aspiration is much better control, provided you have all your parameters of the bottle height, your irrigation flow and aspiration, and your wound that is very well maintained. If the wound is big, the chamber is going to collapse. If the wound is tight, then again there is a fluctuation. Each time you buckle the cornea, you compromise endothelium.
Thank you for the expert comment. The case which I showed you that I did the irrigation aspiration, the phaco was ready, everything was there. But when I entered into the anterior chamber, I think Professor Qadi haven't seen that what I have did with the capsule actually. The capsule was not a triple C in this case. It was torn inferiorly. So when in these cases you don't have an intact CCC margins, you have a torn capsule, in which case I was having a torn capsule. You see that I used scissors to cut the fibrosed anterior capsule. So in these cases where you don't have the intact margin of the capsular axis, then sometimes you can have a tear in the posterior capsule, and that is a disastrous. So I thought a lot of times, 100 times before I went to the irrigation aspiration. The first step was when I entered into the anterior chamber, I just aspirate the anterior cortical matter, and that was so soft, and that actually make me to decide that I should go for the irrigation aspiration, and that will save my posterior capsule as well as the tearing of you can see protected the bag. That was not a complete bag, but that was an incomplete bag. So I have to protect that bag. That should not go around the posterior capsule, and that was the only reason I go for the irrigation aspiration of this particular case, and that was the reason I showed you this case. Otherwise, phacoemulsification is definitely a choice that you have to go in these cases, phacoemulsification, and in later cases, as I showed, you have to remove the sutures, If the patient can wait, usually when the patient comes to you with the corneal transplant, they have high expectations that we have to see, we have the visual outcome very clearly from the first day or after, but this is a counseling. This is not a cataract surgery. This is not trifocal IOL that you will see after a few hours, a crisp vision, 6/6. So this is a corneal transplant. You have to ready for every complication. So that is the reason that I always go to remove the sutures, particularly in cases of keratoconus, remove the sutures, go for the calculation of the IOLs, choose the toric IOL, and then your patient will have a very satisfactory result. Any other questions? Thank you.
Thanks, Dr. Khalid Mahmood, for a wonderful presentation and wonderful discussion, questions of Dr. Kazi and Dr. Miguel. Thank you very much. It was a lot of knowledge that contributed to all of us. Now, I have a presentation. I am Professor Abdul Majid Malik from Fatima Memorial Medical College and Hospital. Topic is on congenital cataract and how to achieve a good posterior capsulorhexis and antivitrectomy, and that is required for these patients. So the people bring their children with the problem of cataract, white pupillary reflex, and people have a severe rehabilitation problem. They have leukocoria, squint, and the way they present these patients. And now, what are the indications of surgery in these patients? Any lens opacity more than 3 millimeter, anywhere in the lens, with or without nystagmus or squint. Surgery, when to do surgery, very important, because we are not clear about the timing of the surgery in patients. Amblyopia is very, very serious complication that can occur if it is delayed. So if it is dense unilateral cataract, preferably should not be delayed beyond 4 weeks. Dense bilateral cataract, maybe 6 weeks with 1 week gap between the two eyes, not more than a 1 week gap. Again, amblyopia is likely to come in. Now, how to do and what type of phaco incision? Preferably a small limbal incision, 2 or 3 steps, not a single step, 2 or 3 steps, that will be sealing more safely. Generally needs 10-0 absorbable suture. If not available, then nylon is okay for wound. If there is fishing, the guides tell that we should always suture the patients, these pediatric patients, even if the wound is a good one. But in my experience, I have seen if there is no fish mouthing and if you have 2 or 3 step incision, suture is not needed, because once there is suture, then you have to remove a suture again and you have to sedate the baby. Some people don't agree for multiple anesthesia or sedation of these children. Other pearls for these patients, anterior CCC. It is always difficult because it is stretchable capsule. Run away rhexis is very common. So you have first to stain the capsule. Stain not only colors the cataract, it makes the capsule more stable. And after making a cut, it runs away not as easily as otherwise. We will use soft shell technique as already discussed by Dr. Khalid, with dispersive as well as cohesive visco to prevent the endothelial damage in the baby. He has to live a long life. We should have cystotome, capsular scissors, utrata forceps, and Vitis cutter, mandatory parts of our armory. If cutter is very soft, we can do lens aspiration and we may not need hydrodissection in these patients because cataract is not that adherent and comes out very easily, even in gummy and rigid cataracts. The more important is posterior capsulotomy. Now, what are the indications? It is mandatory for children under 8 years of age. Uterine forceps or vitrectomy handpiece serve the purpose. Generally, anti-vitrectomy is done for children more than 5 years of age. 5 to 8. It has to be done for all children below 5 or 6 years. Because if we don't do it, there will be opacification of the anterior vitreous face in these patients. Other parts, IOL implantation. I will ask my colleagues for their experience, but I generally don't implant IOL before the age of 18 months. So, because in my experience, there is a very quick myopic shift, not only my experience, but from the literature, it is very quick myopic shift in these patients if earlier implantation is done. So, if possible, we should delay implant beyond 18 months of age. Well, we can do surgery and we can prepare the patients for surgery earlier. Multi-piece foldable IOL implant in the sulcus. The haptics in the sulcus and optics capture is the best technique. For biometry and IOL power reduction, generally we apply rule of 8 minus age. Say if the child is 2 years, so we will reduce 6 from the power of biometry. So that makes it easy, and even if myopic shift is there, we can combat with it. Presently, various people do various techniques. Most common is the anterior technique where we do cataract extraction, posterior CCC, anterior vitrectomy and IOL implants. But some people do vitrectomy after implantation of the IOL, considering it more safe procedure. But if you have double shot technique, then the first one is the better option. We are surgeons, many of them go for pars plana, anterior vitrectomy and lensectomy. After the 5 years age, we can go for a routine phaco like elders, but with posterior capsular access and anterior vitrectomy up to the 8 years of age. So there are 2 videos. This is the anterior technique in which we go through the anterior chamber with this phaco knife. I don't do many cuts. So side port, both of these, side port as well as main incision, are 2-step. We have been saying that we are doing 3-step incisions, but actually if we see later with anterior segment OCT, they are 2-step. 2-step is quite safe an incision. So, fill the anterior chamber with the viscoelastic, double shell, I have already told, anteriorly dispersive and posteriorly cohesive. Anterior capsular access is always a problem. Welcome, sir. Welcome. Please take your chair. Chairman, Dr. Ziaul Mazari. He was busy in another session on glaucoma, and now he's back to our pavilion. Thank you. So, rest should be around 6 millimeter as we generally do, 5.56. Here, uterus serves the best purpose. There is already this cohesive visco, so it does not allow it to spread. Next, this hydrodissection. This patient underwent phaco. Phaco is always easier than simple aspiration, even if soft cutter. It takes less time and takes the nucleus en bloc. Now, having done aspiration of the lens, the next step is the most important. Just make a nick, small nick, here. And then enlarge it with the same uterata forceps. Pressure is already there because of viscoelastic. Don't let the chamber to collapse, because then this recess also will go out of hand and it will go to somewhere away from the visible area. It is smaller than anterior recess, maybe half millimeter or so. Now, once you have done this, next step is make a separate port for vitrectomy cutter and do anterior vitrectomy around 3 millimeter of the anterior vitreous is cut, because I have seen that patients who have undergone this surgery, not only that posterior capsule opacifies, but if you have not done anterior vitrectomy, anterior vitreous also gets opacified. Spurs appear on the top of the anterior vitreous, and again the problem remains of amblyopia development. So after filling the space between the anterior and posterior capsule with viscoelastic, some people go for multi-piece lens, but if everything is fine, single-piece lens is also very good, and I feel more comfortable with it. Just dilate into the posterior chamber. Generally, vitreous of the baby is very, very stiff and not easy. If the lens subluxates into the posterior chamber behind this posterior axis, it does not go back. You can take it out easily. Generally, we apply suture in very young children. So that was the first one. This is another case. Here the problem was with the posterior capsular axis. It was very dense and it was getting out of hands. So the technique was a bit different in this patient. Again, same procedure, dye it to make the capsule a bit rigid and colored. Here with the number 11, first made a half thickness cut, and then with this keratome entered the anterior chamber. You know, this is very common finding in soft cataracts. Sometimes we come up with this milk coming out. We have to be very careful. With very low technique of aspiration, you can take it out. Now, this is not the simple cataract. This was some complicated cataract in the child due to some of the metabolic disorder. And there were adhesions and calcifications on the capsule as well as within the lens matter as well. Anyway, anterior capsular axis went easy. So that was the area of anterior capsular axis. No aspiration. In this patient, phaco was not done by manual. Aspiration was done because nucleus was not hard, it was just a cortex with calcifications here and there. After that, the next step is the difficult one of posterior capsular axis, cohesive OVD. Make a small cut in posterior capsule, generally 3.5 to 4 millimeter ultimately is the PCC. Now here the capsule is very, very stretchable and it does not follow the routine extension of the axis. If we force, it can either be dislodged from the zonules or it can run away into the invisible area. So in these patients, we have to be vigilant, use cutter and make a smooth capsular axis with the vitreous cutter. we should not be afraid of using cutter here. We are surgeons, they are good, but other surgeons can also do wonderful use of vitreous cutter. So we have beautiful posterior capsular axis in these patients. Slight change in the technique. This injection canacart or triamcinolone to stain the vitreous, if at all it is there, it should be cut away. Again, fill the gap between the two capsules with the viscoelastic and then place lens over there. So there are two scenarios, a simple one and a problem one, in which we do capsular axis, posterior capsular axis, and implant lens within the bag. It will prevent PCO, prevent opacification of the vitreous phase, and better results of surgery, and amblyopia development will be prevented in these patients. So these are the complications which can occur. I have had a small study of 40 patients. I work in a hospital where there are so many pediatric patients. So out of these, because there was no capsule and no antivitreous, so these things didn't happen much. Anterior highlight phase was seen in two phases. They are actually hanging from the margin of the posterior axis. Pearls were hanging from the margins. Pupil membrane, again, the use of triamcinolone avoids inflammatory reaction in addition to staining the vitreous. Glaucoma is almost universal complication and likely complications in pediatric surgery, not only because of surgery itself or steroid use after surgery to prevent inflammation, but sometimes associated angle anomaly is also existing in these patients. So that should be very, very meticulously treated. We may be treating cataract very well, but the baby may be losing vision because of cataract. So this was the same study I have told. This type of opacification, dense opacification develops in these patients after surgery like this, if it is not done, if PCC is not done. So we have to apply JAG, but for elderly small babies, it is difficult to apply JAG. We don't have the machines to do JAG under GA on the bed. This is the pearl which appear at the margin, but they don't go beyond because there is no vitreous here in this area. They just linger around the margin of the axis. This is a very common complication. So we should be using steroids freely before surgery, during surgery, intracameral use, and after surgery as well. Otherwise, this inflammation is very, very severe in these babies. So this is the message. Always perform posterior capsulotomy and antivitrectomy to ensure clear media and proper visual development and rehabilitation in these children. Thank you very much for patient listening. Any question and comment? Thank you.
Thank you, sir. I'm Dr. Nazli. Thank you for an excellent presentation. I would like to add few points. Because of increased scleral rigidity in pediatric patient, I go for sutures in all patients. And the younger the child, the more is the scleral rigidity. So ideally, and it should be done almost in all infants especially, suturing should be done. And what I do in, if the child is, when you go for posterior capsular axis and anterior vitrectomy, if the child is less than 6 years of age. But you should go for it if the child is more than 6 years of age. If you think the child is not cooperative enough to sit on the YAG laser later on, because it's universal in pediatric cataracts, PCO. And if there is nystagmus, so one should go for posterior CCC and anterior vitrectomy. You mentioned, yes, so this multi-piece can be implanted in the bag if you don't have the capsular support, bag support, but I am planting these multi-piece IOL in the bag. So it's meant for both purposes. You can implant it in the sulcus, you can implant it in the bag. Phaco, I think phaco is, you don't need phaco power in such patient because the cataracts are soft, they are not dense. So automated IA or manual IA can work here. And you use 350 millimeter of vacuum. Do you think, isn't it high because it will produce traction on the vitreous base and can, so isn't it high? Because I keep it at 100. Yeah, no, while you are doing anterior vitrectomy. I personally keep it 100, but I'm asking your suggestion are, okay.
It should be low vacuum, definitely. 150 to not more than 200.
Okay,
I generally prefer 200.
Yes,
okay,
200 is okay.
okay, okay. Thank you, sir.
Thank you very much. Ji Kazi sir.
The most important lesson is you are treating a patient for 10 years or you are treating a patient for next 100 years. So the doctor who's going to touch them should be very, very expert. As Professor Javed said, that the IOL power. Then I tell people that pediatrics, uveitic, and diabetic, these are the patients in which the surgical technique should be non-touch. They are so sensitive that you touch something, then that is forever. You give them steroids, you end up with glaucoma. Their examination is difficult. I see childs with cataracts and with fully cupped disc. The reason being you don't have the gadgets to check their IOP and we don't know how they respond with the steroids, whether we can put them the drops in a proper manner or not. So the doctors who is going to touch them should be very, very experienced.
Thank you. Not only that, it should be very, very good counseling. The things can happen after surgery. Thank you. Ji Khalid sir.
Just a comment actually from our the great teacher, Professor Wasif. When I was his trainee, he was my supervisor. He always used to teach us that when we are going to have the pediatric cataracts, so always remember two things. बच्चों की आंख गर्म होती है और नरम होती है. So these were his words. I am talking in Urdu. Is that the children's eyes, they are hot and they are soft. So he kept on teaching us that always remember when you are going to have the pediatric cataracts, the children's eyes, they are hot and soft. वो नरम है और गर्म है और उसी के हिसाब से you have to see the lot of reactions in the eye and rest of the issues when we are going to have the pediatric cataracts.
So नरम दमे गुफ्तगू, गर्म दमे जुस्तजू. Thank you, Professor Khalid. Or for residents, I always use this sentence. The pediatric eyes are too difficult to evaluate preoperatively, too flexed to tackle intraoperatively, and too reactive to handle postoperatively. So this sentence summarizes the pediatric cataract surgery.
Thank you very much. Professor Madhur Sahak is around. आप सराहे हुए हैं our ex chairman OSP center. Sir, आप आए, presentation है आपकी. He is going to present premium IOL technique not actually premium IOL, monofocal extended depth of vision lens implants, early experiences. No, he is doing the subject and he will be doing it in more detail. As the time passes, newer and newer lenses are coming and we are implanting them. Thank you very much, Sir Mazhar.
Bismillah ar-Rahman. Thank you very much, Professor Majid, and to invite me on this lecture. And I'm just going to talk about enhanced monofocal. It's kind of a thing which has just come in Pakistan for the last couple of months, and we've just started off. A lot of new things are coming up, and I thought I will just give you, in next 7 to 8 minutes, give just a brief talk about it, what we are, just for the initial opening. And what I always say, is it a U-turn? Are we going back from all what we have done? I think so. One sentence which always I say is that it's surgeon's confidence in the ability to recommend the most appropriate IOL to achieve the best possible refractive outcome. And that is, I think so, is the main talk of the thing. And what we have been doing is doing trifocal IOLs, whether it's AT-LISA, fine vision, panoptics, panoptic torics, EDOF. So been doing on for last 2014, and we have been carrying on this with a questionnaire after the surgery, whether what is the quality of life questionnaire, and which say what is the feeling about day driving, computer work, newspaper reading, night driving, hellos, and how do they recommend? So that was the questionnaire which I started from 2014 and just been carrying it on with this thing. And when we did a comparative analysis, I think so there's not much difference between all the IOLs. We found that panoptic had a minimum dystrophic symptom. I think so we're going to talk about dysphotopsia later on, so I'm not going to talk much about it. Neuroadaptability is there. But the important thing which is always at the back of our mind whenever we're doing these cases are the halos, the glare, the night problems with anybody. So that is the thing which is still carrying on in all of this thing. And we know that the premium IOLs can improve all these things. Trifocus may appear to be good for distance near, EDOF may be intermediate, but the cost and side effects, which is the glare and hollows and night driving, is making not even the surgeons, but the manufacturers to come up with other ideas of putting intraocular lenses. And that is what I called this U-turn. And with this thing, what has come is the monofocal extended IOLs which have come in the markets. And what we know that monofocal IOLs were the first one which come, and it is still being carried out as the most common surgery being done, and which is because of its lack of incidence of photoptic phenomena or anything. And I'll just take you along with the different surveys which were happening in 2016, in which we found out the trifocals were 39%. In 17, they reached to 45%. And in 18, 56%. But in 19, again, they again increased to 63%. So if I just recap, in 1919, 63% were trifocals in the premium IOLs, EDOF for about 20%, and the rest are very minimum lenses. And I'll just go to now to 22 IOLs where you will find out that the trifocals has reduced to about 50%. And this is the ESCR survey which has just come out. And increase in the extended depth of focus IOLs to 33%, and enhanced monofocal IOLs to 8%. So this is what is now in the market, and this is what we are saying. So this is this 8% is the one which we are talking about, which is coming up. Again, what is the main concern? This was a question asked, but the biggest concern against performing more presbyopic retina was the cost to the patient and concern over nighttime quality of vision and loss of contrast sensitivity. So this is again, anywhere in the world, these are the problems which are being talked about. With this thing in mind, the companies have come up with monofocal IOLs. Is that still what is the requirement of different patients? And the requirement of patient is watching television in the old age, driving, or still carrying on, and a lot of things. And what we have found out that intermediate vision is the one which is now being taken up with a lot of care. And the extended monofocal are the one which have come up with which are basically a monofocal eye without the risk of having the problems regarding dystrophia and along with the glare and the night vision problems. What has happened is that everybody is still thinking about when we ask all the experts whatever their feeling are, still there is a problem. And with this in mind, these were the different lenses which has come on the monofocals, in which Evolux has come in Pakistan. Ray1, EMI, Retina, I've just asked them, and they are also coming into the market. And even Fiziol they are also bringing it into Pakistan. And I just want to give you a brief resume that what are the benefits and all of them have got their own way of the optic design, which I'm not going to discuss in the next 7 minutes or so. I will just go. What do they say? Is that the important thing is that they improve intermediate vision and they are comparable distance vision to a standard aspheric monofocal IOLs, and it doesn't affect the pupil size, and the image contrast sensitivity is good. So it's as good as normal monofocal, and it is because of this spherical aberration distribution of opposite side in the middle and the monofocal periphery. So this is how it is done, but I'm not going to go into depth of the physics of it. And in this case, is what we say is the extended focus as compared to a single point focus over there, and that is how it works on this thing. Without going into the more the physics of all these things, but overall they say that the contrast sensitivity and everything is better. And the other thing is that the glistening thing which comes with the hydrophobic lens is not seen in Avalok's. So in what we see that the spherical aberration technology has improved the intermediate vision, and with this thing, I started using about for now 3 months, these lenses are more than about 30, 40 cases we have done. Why I'm not showing the exact results, because most of the eyes, 1 or 2, the complete study is not done. But I just wanted to see that, just to show you that what kind of problems do you feel or you see in this lens. And it looks like a very ordinary lens as you do it. But now what I'm trying to put is you have to put hot water in it, because it's quite a rigid lens. So that is a problem with this thing. So you put some hot normal saline in it, and when you put it in, and it is more rigid as compared to your normal trifocal panoptic or any other lens you see. Otherwise, it has got a small lock into it, and when you remove it, it goes into it. It opens a bit more slowly as compared. So there is a slight learning curve if you are going to start this lens, and if you see it, it comes very slow. You have to be very slow and a bit hard or a bit rigid till it goes into. So what it exactly needs is a bit of warmth before it. So as Professor Al-Mazri was saying, warm, garam, so kuch karna padega before we put it in the lens in. So it is, otherwise I don't think so there's anything specific about thing. And what my post results are coming up, it's that I haven't been able to find any of my patients coming with a problem with glare or night vision problems. Intermediate vision is good, but still, it's still important to know that the 3 questions which I want to ask is the economy and future clinical studies. Yes, this is going to be coming up even in the Western world. Still, the papers are in it. There's head-to-head paper going on between PhysIOL, Rainer and Avalok's coming up, and they have shown that they have got very good results. But the important thing which I thought, and that whether, because my interest is that if somebody who cannot afford a panoptic cost or any trifocal, do we have a lens which can be used as a monofocal extended wave with having a price that we can offer it? But unfortunately, not yet, because even these lenses are quite expensive and they come into the category of premium IOLs. And this is what my aim is, to telling all the companies that they have to bring the cost down, so that at least we can say that we have got a lens which can give you an equivalence to a trifocal with some problems, but it's the cost economy is also. But I think so we are not successful in this stage, and I would request all of the ophthalmologists of here, whenever these companies people come over there, we should press upon them that they should bring the cost down, because that is also very important aspect in this part of the world. And so what important is that we have, I always think about that counseling is very important, financial situation and occupation are the 3 things whenever you are putting, and pre-operative assessment is the most important aspect whenever you're going through a premium IOL. Thank you very much. And this is my, I think so. Thank you very much.
Thank you so much, Professor Mazarita. Any question? So our next speaker, the last speaker is Megur Rikiki. I'm sorry if I pronounce it wrong. And
Thank you, Mugair. He is talking on the flex, still a novelty. Let us give a big hand. Italian.
So, thank you for this kind invite, my first time in Pakistan. Thank you, Professor Kakan, for inviting me. I will speak about the femtosecond laser assisted cataract surgery. If it's really still a novelty. It doesn't work. Don't go on. Okay, these are my financial disclosure. And why we speak always about cataract surgery, because we know that every patient loves the word laser, but nobody what really is. And especially in Western countries, there is a rising demand for this kind of surgery. And there is also a common feeling from the patient point of view that laser surgery is a better surgery and is more safe because they always had the fear to be cut. So from psychological point of view, this is the main reason for the rising demanding, especially in the Western country. But this is really the holy grail for cataract surgery. I will look critically at me and also to the literature. So the manual cataract surgery has established steps, the corneal incision, the search for the perfect manual capsuloresis, and also a lot of technique for nucleus fragmentation that depends also on everyone's experience. So what about the capsulorhexis? Could be variable in shape, in size, in location, and this could also affect the effective lens position. The advantages of femtolaser is that all the steps are precise, and we can decide how much large is the rhexis, how much will be the fragmentation pattern, and we can add also arcuate incision to manage the astigmatism. The theory is that a better capsuloresis will help us in a better effective lens position. This is what the company that sells the femtosecond laser claims to us. But this is really true. So for sure, the laser is better than us in reproducibility of capsuloresis. But if we look at the literature, the real revolution in effective lens position was not the femtolaser, but the transition to the continuous curvilinear capsulotomy. This revolution really helps to start from a more than 1 millimeter decentration with a cane opener to an average decentration of 0.28 millimeter. And now the question is, how, if we go more precise than 0.28 millimeters, this really will affect the effective lens position? So, if we look at the literature, we will see how, for example, a normal, a conventional monofocal IOL, the J&J PCB, if decentered more than 0.8 millimeter, it will not really affect nor the effective lens position and neither also the power. And also the tilt. If we have a tilt which is further than 2 grades, we will not have any effect on the power and the effective lens position. So, how much 0.2 millimeter decentration affect the vision? Not much. So, for this reason, femtosecond laser cataract surgery will not help in effective lens position. And this is very true, but this is true in the average eye. So in the average eye, the femtosecond the good capsulolysis of a femtosecond laser will not affect the final results. But if you look at very abnormal eye, like myopic eyes, we will see that the more precise capsulotomy that we can reach with the femtosecond laser will result in a better IOL overlap and less chance of phimosis. And especially if we put premium IOLs in a very long eye, in these cases the femtosecond laser really will help us in reach the best refractive results. And there is also some priceless evidence that is not published that we can observe at the slit lamp when we see our patient after time. So what about lens fragmentation? For this reason, to me, the femtosecond laser really helps you because the manual lens of fragmentation is directly is direct to the patient, to the surgeon experience. So any one of us, based on our experience, could do fragmentation in a lot of different way. What is the advantage of a laser? That we can have a laser fragmentation of very precise, and we decide the pattern. So in this way, the most important things for safety is that the nucleus is divided from the posterior plate. And to me, this is a very safe surgery, because when you have posterior plate divided, you just enter with a phaco probe, and in a normal cataract, this is just a phaco aspiration. So in this way, we have for sure less incidence of PCR, and we can go much lower with the phaco probe inside. So the impact on effective phaco time is evident. So especially in a very hard cataract, we will use much less ultrasounds. And to me, the pros is that you can add also arcuate incision that helps you to manage astigmatism up to 3 diopter without using toric IOL. The cons, for sure, is very expensive, and you have to add these values to the patient bill. Is not applicable in many demographic situation, and in normal eyes, to me, really does not make too much difference. And to me, the worst fault of a femtosecond laser is that will not help you in a patient who not dilate very well, in patient who had small pupil, deep orbit, and very shallow anterior chamber. So it will not help you in very challenging cases. So this is the answer to a lot of questions that usually people ask to the femtosecond cataract surgeon. And to me, the best of femtosecond laser cataract surgery is in a hard cataract and in premium lens. For the normal eye, to me, is not really a difference, and you have never to forget the origin, because before to be a consistent femtosurgeon, you have to be a consistent manual cataract surgery. So thank you.
Thank you, Mr. Miguel. Any question and comment? Dr. Mazhar Ishaq, Professor Mazhar Ishaq, General Mazhar Ishaq. I have a question, I'll comment.
I think so. This is a very relevant presentation in regarding, because we are also in the infancy of getting these kind of machines. I am being a user of this machine for the last 7 to 10 years. So I've worked on Alcon first, and now I'm using the Zimmer machine. I think so. Your points are very pertinent. I had a comment. It's a very early when I was doing my residency in UK, and we were transiting from extra cap to FECO. So one of my consultant who was very still into extra cap, he used to say that, look at my surgery. Is there any, because my other consultant has started doing FECO. So he was saying, what's wrong with this surgery? Am I doing anything wrong? What is the need of going for those expensive machines? And we were saying yes to him. And then we used to go to the FECO one chap, and we used to start learning how to do a capsulorhexis. I think so. Over the period of time, the things do change. And now, if you ask somebody to do an extra cap, you're not even going to call him into you will let him sit in an exam for residency. Things are there to come. We have got these problems, whatever we have said, especially of the small people. Can we do anything for the good? But there are some things, I think so, which we have learned from this thing. And doing, I always say that the premium IOs, if you're going to go for them, this machine does help you. And with them, with the premium IOs, and if you have to do some cylinders of less than 1.5, if you've got a sill, and they have got LRI built in so that you can do it over there. So that is also help in our, at least Zimmer machine. So, but the most important thing is going to be the cost and whether it is going to be economical over here, which is still a big question. Thank you very much.
Thank you. My only remark is that the only critical point when you do femtosecond cataract surgery is hydrodissection, okay? Because you have to be very gentle and you have to evacuate the gas from posterior plate. I saw a lot of surgeons who do first time femtosecond cataract surgery, who do vigorous hydrodissection, and then they block the capsule because there was already a pressure in the posterior plate because there was gas. So my only advice is to do a gentle hydrodissection, move the nucleus to allows the gas to go anteriorly, depressurize the posterior capsule, and then go away. Then it's a very easy way to do cataract surgery. Thank you.
Thank you, Dr. McGoy. It was an excellent talk and good discussion. Now I have an announcement. The speakers can collect their souvenirs from Zewa room and sheets from the Zewa room, and tea is ready at the moment in ballroom 1. Thank you very much for accompanying us, having the session in good worth, and all the speakers, particularly from abroad, they have made us more knowledgeable and knowledgeable than earlier. Thank you very much.
Thank you so much, ladies and gentlemen. Have a nice day.